Okay, here we take a look at the Circle of Willis again, and this drawing is always a little overwhelming for me, so we're going to try to break it down. You just kind of want to look here. You've got the vertebral artery here and a vertebral artery here, and they join together to form the basilar artery. Then from the basilar artery, they bifurcate into the right and left posterior cerebral arteries, so those are these here. Now, meanwhile, you have the internal carotid artery. And again, this picture is always overwhelming to me, and so this is what I have to do. I have to understand that this middle cerebral is going superior up to the head. My drawing tool isn't working very good tonight, so I'm sorry I can't write that on there, but just try to imagine this middle cerebral artery going up superiorly into the brain. Same here. Okay, so here you have your internal carotid. It bifurcates into your anterior cerebral and your middle cerebral. This middle cerebral is going up anteriorly into the head. So this internal carotid, you're looking at it as if it's coming down from the neck. Again, that takes a little bit of brain power to kind of get oriented to that. But just think of these middle cerebral arteries are going up. They're going superiorly into the brain. Okay, so the internal carotid artery bifurcates into the anterior cerebral and middle cerebral. The two anterior cerebral arteries are joined by the anterior communicating artery. So that's that little bitty thing right there. And then you have these two posterior communicating arteries. These two posterior communicating arteries, they join together the two posterior cerebral arteries with the middle cerebral, or the internal carotid. Basically, these posterior communicating arteries are what join the anterior circulation with the posterior circulation. So again, I kind of like looking at this drawing. It's more of a 3D rendition. It's just easier for me to visualize. So again, you've got your internal carotid artery. It bifurcates into here is your anterior cerebral and your middle cerebral. And again, that middle cerebral keeps going up into the brain. On the left side, you also have a anterior cerebral and middle cerebral, and then you've got this anterior communicating that join the two anterior cerebrals. Meanwhile, you've got the right and left vertebrals. They join together to make the basilar, then bifurcate to make the right and left posterior cerebrals. And then you have these two little posterior communicating arteries that join everything together, which makes the Circle of Willis. Okay, we are moving on now to the spinal arteries, and there's basically three main spinal arteries. There's one spinal artery that runs along the anterior surface of the spinal cord, and then there are two posterior spinal arteries that run down along the posterior surface of the spinal cord. And these are fed by various branches off the aorta. Up in the cervical region, the spinal arteries are fed by the vertebral arteries, or little branches off of the vertebrals. And then in the thoracic aorta and lumbar aorta area, the spinal arteries are fed by intercostal arteries. Okay, so here is a vertebral artery. Again, it's coming up. It joins to form the basilar. And so what I want you to see then is this very thin line going down in the center of the neck. That would be the anterior spinal artery that runs along the course of the spinal cord on the anterior side. So this diagram is showing how you put the catheter in the aorta, and then you have to select out each of these intercostal arteries in the thoracic and lumbar area, and then one or many of these intercostal arteries then feed the spinal arteries. And so this is showing you that the spinal arteries are very, very teeny tiny arteries, one running on the anterior side of the spinal cord, and then there's two running on the posterior side of the spinal cord. And again, they're fed by many different arteries, and mainly being these intercostals. So here's showing you an arteriogram of an aorta, and then again you see these teeny tiny branches off the aorta, and those are the intercostal arteries. And then those intercostal arteries then go to feed the actual spinal cord. Well, they go and they feed, those intercostals feed into the spinal arteries, and then the spinal arteries then go to feed the spinal cord. Okay, so here's showing, again, here's the catheter. It has injected into one of those intercostal arteries, and then from the intercostal artery, it is now feeding into one of these spinal arteries here. Okay, now we're going to talk about stroke. Lots to talk about with this neurologic section. Now we're moving on into stroke. There are two types of stroke. There are hemorrhagic and ischemic. The hemorrhagic is your bleeding stroke. The ischemic stroke is your blockage. So if it were me, I would have called them bleeding and blockage. Bleeding and blockage. But they didn't ask me, and so instead the bleeding stroke is a hemorrhagic stroke, and the blockage stroke is the ischemic stroke. Now, the reason why we're talking about stroke is because there are interventional procedures that are done to help prevent a hemorrhagic stroke, and then there are procedures that can be done to help fix an ischemic stroke. So we'll start with the hemorrhagic stroke. A hemorrhagic stroke oftentimes is caused, it's always caused by a ruptured blood vessel, but that blood vessel usually ruptures because it had an aneurysm or a bulging, and so we can go in and embolize that aneurysm, cut off the blood supply to that aneurysm so that it's no longer being fed, so it no longer becomes weaker, and so then it will not rupture. So here's an example of here's an internal carotid artery, and when they injected the dye, there's a big bulge, there's an aneurysm filling with contrast. And so what they did then is went in and filled that bulge, filled that aneurysm with a coil, which embolized, which cut off the blood supply to that aneurysm. And so now the theory is that aneurysm will no longer grow and become larger, and so it won't rupture. And here's kind of a graphic of what that kind of looks like. So here they've shoved a bunch of embolization coils into that aneurysm to cut off blood supply to it. Okay, the ischemic stroke or the blockage stroke, that all starts with atherosclerosis or accumulation of plaque. And that plaque is highly thrombogenic, meaning it's very prone to forming a blood clot. And so when that happens, then as an interventional procedure, we can go in and try to do thrombolysis, which means to break down or dissolve a blood clot, or we can do thrombectomy, which means to actually remove the blood clot. And so after the thrombus then is removed, then we still have this issue of the lesion, which is the accumulation of plaque, which is the atherosclerosis. So then we can go in there and do an angioplasty, which is inflating a balloon to make the lumen bigger. And then of course we can place a stent, which is a device to keep the lumen open. Okay, I need to back up for a minute and talking about the embolization, which again is a procedure to occlude or block a blood vessel. Here's an example of it done for epistaxis. Epistaxis is a nosebleed. That's a medical term for nosebleed. And so here they have injected the external carotid artery. Remember, that's the one that feeds the face. And so here we're seeing what's called, they call this blush in the nasal cavity. And so they've gone in and embolized that artery, and so now after embolization, they've essentially stopped the nosebleed. So they can do that embolization procedure for many different reasons. For an aneurysm, to prevent it from rupturing. They can do it for an artery that already has ruptured. They can do it for an AVM, which is an arteriovenous malformation, or they could do it for a fistula, which is an abnormal communication between the artery and vein. And so this example is done off of a branch off of the external carotid artery. It could also be done on spinal artery for those same reasons. Okay, and going back here then to the stroke, the hemorrhagic and ischemic stroke. Also, when you're working in here working on the cerebral arteries, remember the cerebral arteries are what's feeding the brain. And so it's important a lot of times to use what's called a distal protection device. And so that could be an occlusion balloon. So basically they inflate the balloon distally to where you're working. So let's say we inflate it here distally. Then we do the angioplasty, we do the stent placement while that balloon is inflated, and then after the intervention then we go back up with a different balloon, or I'm sorry, a different type of catheter, an aspiration catheter, and the theory then is to aspirate all of that debris that was caused during the intervention. Another type of distal protection device is what's called a filter wire, and it's a device that is a mesh, and again it's placed distal to where you're working, and it's like a little net, and so again you deploy that little net, that filter, and as you're working the debris that's caused while you're working then is caught in that little net, and then at the end of the procedure then you retrieve that net and all of the debris that was caused is caught in that filter mesh. The advantage over the filter wire over the occlusion balloon catheter is the filter wire, is a mesh, and so it does allow some blood flow while you're working, whereas the occlusion balloon catheter, it completely occludes the circulation while you're working. Okay, so briefly now we're moving on into vertebroplasty and kyphoplasty. And so here, vertebroplasty and kyphoplasty is for the treatment of compression fractures of the vertebral bodies. And so this is a percutaneous procedure where they stick the needle in from the back. It gets put into the body of the vertebrae. There's a balloon inflated, and that balloon that inflates creates a space. Then they fill that space with cement, and again that treats compression fractures. Now the difference between vertebroplasty and kyphoplasty is with vertebroplasty there's not a balloon inflated. They skip the balloon part. They just put the needle in and inject the cement and done. Kyphoplasty, there's an extra step where they inflate a balloon to create a space to inject the cement. Okay, so then this is what an x-ray of a spine looks like after a vertebroplasty or kyphoplasty procedure has been done. So again, you can see the cement within the vertebral bodies. Okay, and then the last interventional procedure mentioned in the neurologic category is the discogram. And so again, this is also a percutaneous procedure where they place needles percutaneously, through the skin into the actual disc, and so the disc then is the cartilage in between each vertebral body. So they put a needle into the actual vertebral disc, they inject contrast, and then, again this is what it looks like on an x-ray. So in the intervertebral disc spaces they inject contrast into the disc, and while they're doing this, while the needle's going in, and a lot of times this procedure will mimic the pain that the patient is having. So if they, so if they stick the needle in, here, like say here at L5S1, and the patient's like, no, that's not really the pain I'm having. They're like, okay, well then that's not the culprit. Then they'll be like, okay, and they stick the needle into L4, L5, and then the patient's like, oh yeah, yep, that's the pain I have. Yep, that's it. Then they know then for sure that that is the culprit disc, and so they they use this for evaluation to make sure, before they do surgery, they're doing surgery on the correct disc. Okay, so that concludes neurologic, again, neurologic pertaining to the brain and spinal cord. Definitely a lot of anatomy in this section. So again, just takes a lot of repetition. Be sure to print out everything and to practice, going over all of the images, knowing what everything is.